Thank you, Milton. Yeah, so as you can imagine, that's where Rwanda is located. But I'm not having a hard time with the weather or anything like that because whenever I come to the US, normally it's 3 layers of clothing or some, but in California, you know, this is how the weather is. So as Milton mentioned, he visited, I think that was 4 or 5 years ago. And, you know, just looking at the possibilities, how can we use telemedicine to be able to move things forward? But also the aspect that I'll bring forward is really how we are using it in education, in training the next generation of health professionals. So what I'll start with is, what comes to mind when you hear Rwanda? Just blurt it out, you know? Yes, genocide? Huh? Hotel Rwanda? Uh-huh. Yes, gorillas? Uh-huh. What else? Anything else? Women empowerment, yes. We have exactly. Uh-huh. Anything else? Yeah, so that, yeah? Free? Yeah, and the reason why I'm saying this is for the last few years, it was always the genocide. You know, that's the first thing that this is a true story. I've talked to people and my friends and family, different people. You meet someone and they're asking you, so did you kill someone or are you about to get killed? And that has been the narrative for so long because as you can remember, for some of you that know, the genocide happened 23 years ago where more than 1 million people died. So everything was depleted. But now, you know, yes, the gorillas are still a big part. You know, this is one of the convention center, one of the area shots. Everybody is showing this now. If you want a vacation, one of the things that you were saying about tourism, this is called Bisate Lodge. It's up in the volcanoes, close to the gorillas. So what I'm saying here is that besides telemedicine, there's a lot more other things that you can be able to do. So this should be your next vacation spot. So I'm the program manager for Tulane University. The Tulane University, which is based in New Orleans. We operate in Rwanda as an NGO. We've been there since around 2000, involved in setting up the School of Public Health. So we've been involved in the health sector for a while with a focus on education, but that has allowed us to sort of like see where things are headed and try to innovate whenever we can. That's how we invited Milton, because we saw that there was a need. You're trying to train people, because we work closely with the University of Rwanda, their College of Medicine and Health Science, and we realized, you know, it doesn't matter how much we do, it's not enough. And as I was telling the different people I was chatting with this week, it's encouraging for me to see that even in the United States, as a developed country, it's not enough and you're moving towards telehealth and involving technology. And as a country, really our emphasis, our president really pushed this forward and said it has to be technology or we'll not be able to overcome this. Now, FYI, I'm not a government official or anything like that, so it's not like... But yeah, the institutions that we work with closely, so mostly it's the University of Rwanda, their College of Medicine and Health Science. The Ministry of Health is also involved in that because we are training health professionals. The Ministry of Education, and then a portion of the Ministry of ICT, because there's a lot that has been done in setting up the infrastructure and the ICT that is needed for that. Now, when Milton came a few years back, this is all that there was. This is what we called telemedicine. It was really just video conferencing equipment in a few. We were involved in deploying two, one at the College of Medicine and Health Sciences, 2 different sites, one in the south and one in Kigali. 2 or 3 of the hospitals had them, and all they did was talk to their partner universities or partners, University of Virginia here in the United States, Harvard University, physicians being able to sit and talk once or twice a week and be able to discuss cases, and that was it. And we wanted to get to the point where we can be able now to start involving treatment of patients, also involve students in figuring out ways to be able to reach out to talk to their professionals and all that. But the technology wasn't there. The infrastructure wasn't there. We're still lacking in that in the rural areas. For example, we wanted to do one of the pilots with Milton when he was there, but we couldn't because there was no internet connectivity in the rural areas. Now that has changed. Just a few of the stats. About 18,000 health professionals from 11,000 in 2008. The specialized physicians represent 28% of that. More than 70% of the population is in rural areas. 70% of the population on health insurance. We have universal health insurance in Rwanda. And of course, its contribution. So it's always an interesting discussion when I talk to people with the discussion that is going on around in the US right now. So there's really need for us to be able to use technology to be able to provide healthcare. This is a bit on how the system is set up. So we have 5 main teaching hospitals. And then there are district hospitals going down to health centers, about 416, and what they call health posts. Health posts are not health centers per se, but they can be able to provide some of the basic needs. And then there's a network of 45,000 community health workers. These are volunteers. Now, the biggest challenge is that all the specialists are in the 5 district hospitals, the teaching hospitals. And then we have students because third-year medical students have to do their clinical service. And they rotate through some of the district hospitals and health centers. How do you reach them? We have very few specialists. How do they reach their students? So that's how we started looking at this. What enabled this is the political will. There are no other ways to put it. And I won't go into the details of the different strategies that have been implemented, but it's really the government being able to say, you know what, we need internet coverage in the whole country. We need fiber optic coverage in the whole country. And as I speak, by the end of the year, right now it's at 97%, and they're hoping that by the end of the year, it will be at 100% 4G coverage in the country. Now, it does not mean necessarily that everybody will be able to afford the 4G, but at least the health centers and the different critical places that need it, some have fiber optic, others have 3G, others have 4G. These are some of the objectives, the boring stuff. Yeah, so the telehealth services that we're doing. So primarily, it's for the health professionals. Now, to make sure that continuous medical education for the health professionals, for them to be able to diagnose cases and discuss with their partners, again, like I said, universities in the US and other places. But it's also for the students, so that the professionals can be able to supervise their students, can be able to provide guidance. But there's also remote patient care and monitoring, because again, like I said, we have specialists in 5 of the district hospitals. What happens when there's a critical case in one of the districts? We can use something like this. And then the rest of the holistic approach to telemedicine, where we are looking at store and forward applications, and then workforce development. This is huge for us, because we can talk about the technology, but we have to take the time to build capacity for the people, so that, for example, if you bring in people, I loved what the different people I've been meeting, what Cloud DX, what they're doing, but we do not have enough machine learning professionals in Rwanda to be able to do something like that. How do we start building capacity for the next phase? So the CMHS approach, which is the College of Medicine and Health Science, what we've done in our work is that we developed an online learning system for them. Moodle is open source. Even some universities here use it. Moodle, Blackboard, different systems, but we adopted Moodle. We plan on purchasing a few of the Logitech cams. So I think we purchased, for the project that we're going to be doing, we purchased 15 of them. Very few, I know. And we've purchased a few licenses of VSee, and what we want is to deploy it and make sure that we can link those places. So again, the first phase is the specialist talking to the students, but with that, we can be able to also help the specialist monitor, deal with nurses, and we did one case study, and I'll be able to show you that using VSee. This was a test case that was done in December of 2015. What happened for diagnosing of ENT cases? So what we did, one of my colleagues at the College of Medicine, Mr. Joseph Ngenzi, we took some, they set it up in Nyagatare, which is in the northeast. Took 30 minutes to train one of the professionals, and then started, this is just set up in a tent outside, and then started doing diagnostics. So they had 2 ENT professionals on site who were doing the triage and the diagnostics there and taking down their measurements and what they agree on. And then this gentleman in the bottom right is the one who was receiving it in Kigali at the central level. And then they later compared their cases. And out of the 9 cases that they did, it was 9 of 9. The diagnostics, everything was right on. Now, they had challenges when they were doing it because the connection wasn't that great, so they ended up sending the images. But the diagnostics, they were able to get this and they were able to provide feedback. So there is, and this, again, this was 2 years ago. Now with better quality, they can be able to do it on video in real time. And by the way, one of the other advantages why we considered VSee is because it handles really well with low bandwidth. It's one of the things that are really, that blow our minds. Again, this is, like I said, this was the current setup, but the challenge with the way it was set up is that you had expensive video conferencing equipment in a few select sites, and sometimes you'd go back there after a year and you want to find out how they've been using it, and they tell you, no, the IT professional is not there. The IT officer hasn't been in office. We couldn't find this specialized cable, the HDMI cable or something like that. Now, which is why we said, let's use a simple Logitech cam where you can just, it's plug and play. You plug it on your laptop or your desktop and you can be able to use it right away. I'm left with 2 minutes. Okay, we're not bad. Yeah, so this is just a shot. It was distorted. This is just a shot of the backbone of the internet connectivity in the whole country. Like I said, we're at 97% at the moment, but expected to be at 100% by the end of the year. So these are some of the things that we're aiming for. Postgraduate training of physicians in specialty areas. Knowledge exchange across sites within Rwanda. Again, the 5 different teaching hospitals, but also for the knowledge to be able to trickle down to some of the other sites. Facilitating remote diagnosis and treatment between referral and district hospitals. Improving access to medical knowledge, both within Rwanda and worldwide. Because besides just being able to do it in Rwanda, there's need for more partnerships. There's need to be able to link them with what is being done outside the country. Now, these are some of the applications and some of the providers that are coming into the country. Babylon Health started last year. They're currently the only telehealth application in the country, company that is in the country doing pure telehealth. And it's picking up. It's not yet there, but it's picking up. This is Zipline. Some of you might have heard of it. They're doing drone delivery of blood supplies. Yeah, so the drone just drops it off, and this is a lab technician picking it up. The doctors are really loving it because they can be able to, if they're about to get into surgery or the stores are running out, they're able to order it on their mobile application and the blood will be delivered. And why am I saying this? As you know, Amazon and different tech companies here in the US have been trying to get drone delivery worked out for the past few years. Hey, come to Rwanda. The government will help you set it up. Thank you.
Is there some time for some questions?
Thank you. Very good talking. Actually, Melton, I've been in Ghana 35 times. And I've lived in Africa, West Africa for 5 years, and Rwanda, one of the countries I visited, but I visited about 32 African countries. Okay. So I'm not sure this is the best one, but it's one of the good one.
Rwanda's going to be your best.
Okay. I'm just joking. Okay, for the telemedicine, actually in Africa, my experience really, just like you mentioned about the first is education and shared experience. Well, drum deliver, but the most critical issue is running water and electricity. So I working with UNICEF. Even they are trying to use a generator to power the OR room before they go into OR. So telemedicine in Africa, when we're in Ghana, we actually the first time we in telemedicine in 2002. That time actually cell phone and not communicate with a laptop. What we do, and we are in KwaZulu in South Africa. We actually really help the South Africa to reduce malaria, and just deliver the mosquito net, simply mosquito net. And we also in Ethiopia for the HIV positive mom and who can not able to breastfeeding, but we just give them like a powder milk for the new baby. But unfortunately, the critical issue is not a powder milk, it's water. So I think in Africa, there's really a big push to be really in the telemedicine because they already jump into the mobile health, mobile phone rather than the line. That's I think I'll give you a comment. It's very good. Thank you.
Yeah. I mean, I couldn't agree more. I didn't get the time to be able to look into that, but it's true. That's the critical need, and the government is doing all it can. There are places where there are solar power generators because the electricity is not yet there. Some of the plans that I was talking about is the Niki 2 plan. It's the last mile connectivity, just making sure that those health centers in the districts and different places. I mean, even in Kigali, in the capital city, we still have times where there are blackouts. It won't take a full day or something like that, but we're trying to figure it out. So I agree, water, electricity, that is needed.
How you doing? It's very impressive. I actually spent half of my time in Morocco. I commute back and forth, and so I love telemedicine. And so because I'm able to still run my company while I'm in Morocco, and I'm actually trying to introduce it over there. And my wife's uncle works for the Ministry of Health in Morocco, and he covers all the south. That's his whole region. And so I was trying to talk to him about, how do we introduce this in Morocco? But he's saying that a lot of patients want to see a doctor. They try to do like the telerad, and they get bothered because the radiologist is not going in there talking to them. And then another issue was they don't trust credit cards. It's cash. Everything's cash. Was there a way, or are you, I mean, it sounds like the leader of Rwanda, he wanted to get this started, but do you have any suggestions on, how do you have to start from the top and go down, or do you change the culture of the credit cards, seeing, the whole, everyone uses a smartphone, but they don't want to use a credit card?
Well, I don't want to say it's a top-down approach, but sometimes you can't even use a credit card. For example, in Rwanda, yes, I do have a credit card, but most payments are made via something called mobile money. So a few people use credit cards, but we mostly use it if I'm buying something in the US or something like that. But it's mobile money because not everyone has a credit card, but everyone has a cell phone. So there's a whole platform together with telco companies. It's called mobile money, and that's where the payments are being made. So I would say you need to adapt it to what's happening on the ground, and we can discuss this more. A lot of it has to go into sensitization and talking to the people. Like you said, one what I think one of the biggest challenges when you start introducing something like this, even when they were doing this pilot with VSee, guys were like, okay, so you're going to stick this thing into my ear and someone is going to see it in Kigali? You have to be able to talk to them. You have to be able to show them the benefits. I wouldn't have time to go into all of it, but there's a lot of sensitization that goes into this. Something that is done in Rwanda, the last Saturday of the month, there's community service for throughout the whole country, from in the morning from 7 a.m. until 11. After the community service, like in your neighborhood, people come together and they'll discuss these things. So if there's a new initiative like this, they'll start talking about it. People will ask questions when there's no government official to be there and sort of like feel like they're intimidated and have to respond to it. So what's, in the papers, they'll say, yeah, the president has done all this, but there's a lot of groundwork that really goes into it. So we can definitely discuss more, but I would say adapt it to what's applicable on the ground. It may not be credit cards. Before that, there were payment systems where sometimes, there would be agents in the neighborhood, and that's where you would go and pick the money. So we can discuss more, but credit cards don't always work in the developing world. Yeah, I guess is what I would say. Yeah.
All right, thank you.
Yeah.
So, any other questions? Okay, thank you so much for that really inspirational.
Thanks.
Yeah. Thank you so much.